rapid insights from our first Wellcome Trust project, because as I say, we're now publishing on this, and I can give information about the publications to get the details. But these questions become very interesting when you start to see them from the side of the tissue providers. The first thing that we need to perhaps realise from what our interviewees anyway are telling us is that the people going through this IVF programme who have been asked to provide tissue, they are IVF patients, first and foremost, not embryo donors. In our world of stem cell science, we perhaps think of them as embryo donors. That's an identity that has very little relevance to them as IVF patients. Their focus is going through IVF in order to get a baby. That then produces what is seen as a slightly counterintuitive and maybe surprising finding to many people, which is this cohort of patients had greater willingness to donate their embryos than their eggs. And the reason for this is because they are very much focused on the IVF process. And for those of you who know anything about that process, it's regarded as a series of hurdles that the IVF patients have to get over each hurdle as it comes. And the first hurdle is producing enough eggs, producing any eggs indeed. So to be asked at that point, as this cohort of patients were, whether they would provide spare eggs for somatic cell nuclear transfer research as well as provide embryos for stem cell research, their response was, no way. I've got past that first hurdle, I've produced eggs, but now I need to produce embryos, and there's no way I'm going to diminish my chances of producing those embryos by giving away some of my eggs, even though I'm told that if I produce more than 12 eggs, it's not going to affect my chances. I'm just not going to do it. Nonetheless, as the process goes through, the later stages are focused then on the transferred embryos. They've produced the eggs, those eggs are fertilised, good quality embryos have been produced, they're then going to be transferred into the woman. And that is the focus. At that point, they're not that interested in what's happening to the other embryos. And indeed, when we were interviewing them, there wasn't much clarity about what this research, stem cell science, what it's all about. That's not to say they didn't feel they had been consented appropriately and then been given appropriate information. It was just, it wasn't really on their minds at the time. They were focusing on the IVF, and if they could help somebody else's research, fine, but just let me concentrate on the IVF. So what we were finding, in brief really as a sort of summary of our findings, was that for these tissue providers, embryos actually had a variety of meanings and a variety of levels of importance, depending on what stage of the IVF process they were at, what the location of those embryos were they inside the woman, were they in the freezer, were they in the lab, were they actually on the screen before transfer, and the quality of those embryos, were they good or poor quality embryos. So rather than just a notion of the embryo, and what does the embryo mean to these embryo providers, what we have actually is an emerging typology when you see it from the IVF patient's point of view. You have embryos in general, which are the key resource they've got to produce in order to be able to get a baby. They then have our embryos, those good quality transferred embryos that may result in our baby. They're the other embryos that they assume are poor quality, no use to them in terms of treatment, happy for them to go to research rather than be wasted. And the notion of the embryo, the morally laden abstract entity that is much discussed in the initial debates around this field, that features actually very little in their debates, in their considerations. They're aware of the debates around the embryo, the moral state of the embryo. They can participate in discussions about it, but it's irrelevant to them. It's not something that has much meaning for them. But the embryos that do trouble them, it's not this morally emblematic embryo. There are troubling embryos, but those are the embryos which they regard as our embryos, the good quality, transferable quality embryos, that somehow ended up being treated as these other embryos and went off to research. And that can happen, of course, depending on any individual clinic's freezing policies. A person might produce more good quality embryos than could be transferred. In the UK, only 2 embryos can be transferred, and we're now moving towards single embryo transfer. And the concern then is somehow good quality embryos that they would prefer to be frozen have somehow gone off to research. So our very broad conclusion from that study is to say you shouldn't be asking for fresh embryos in the first IVF cycle. That can happen quite a lot in the UK, And this recommendation isn't particularly popular with the IVF clinics or the stem cell labs, but it seems to us that the process is so complex that we can't just leave it to chance. People need to be able to go through the cycle first, realise that they have these different attachments to the embryos at different stages, absorb that, and then their consent to donating embryos for stem cell research may well be much more robust. So this then raises questions for our egg sharing project. And as I say, we're in the middle of doing fieldwork at the moment, so I can't really give an awful lot of insight from the material, but we're certainly aware that additional questions need to be asked. And the first question is, are eggs actually more valuable than embryos? Somatic cell nuclear transfer research has often been justified on the basis of, it's okay, we're only using eggs for this research, and eggs are less morally problematic than embryos, of course. Well, morally problematic or not, eggs are clearly highly valued by these participants in IVF because they are that first primary resource. So then one has to ask the question as to whether fee reduction actually exploits those people who are particularly vulnerable or desperate or poor for further IVF treatment. That in turn obviously raises a question as to whether or not fee reduction compromises the autonomy to give informed consent. If the concern is actually to get more IVF cycles of treatment, and you can only afford that by giving your eggs, you may not be thinking too much about what's then going to happen to those eggs when they're used in research. Additional questions, the standard questions, whether the promise of fees or fee reduction constitutes an inducement to participate in research. Now in the UK, I'm not sure about how things are here in the USA, but in the UK we have a very, very muddled position on payment for research and compensation for participation in research and so on. So this isn't a unique question to egg sharing, but it's still a question that egg sharing has to respond to. We can, of course, though, take a slightly different view of this. Instead of seeing egg sharers as possible victims of a scheme that's going to exploit them, we could actually see them as market traders, active negotiators in a tissue economy that's where they value what they've got, they know the value of their tissue, and they negotiate the terms accordingly. And indeed, actually, from some of our interviews, we see elements of that research, of that attitude emerging. But what is clear is, I think, instead of thinking of eggs as an alternative to embryo donation, we actually have to think of eggs and embryo in comparison to each other, but also in comparison to these other techniques, which my colleagues are going to be talking about. So it's not that you use eggs instead of embryos. Each technique and the use of the human tissue has to be evaluated both in its own terms and in comparison with the alternatives. Okay, so then in terms of the wider considerations, it would be easy to think that we're just doing research on tissue providers. That's a self-contained field in its own right, and we just have to deal with the questions. But of course, being a sociologist, I would say, no, this opens up a whole field of other questions, where we have to broaden out, for example, ethical questions to socio-ethical concerns. The material we've produced from our research suggests that we have to think not just of the moral status of the embryos, or indeed even of the providers, but also the socio-cultural status, the identity attributed to those embryos by the providers. We have to look more carefully at the details of the processes of the acquisition of tissue, the processes of consent. We have to understand the social context of autonomy and trust. How influential is it that these requests are being made in an IVF clinic when people are highly dependent on the IVF clinicians? We have to remember the context of reproduction. Many of these tissue providers are in this situation because they want to reproduce. Who then has an interest in reproductive tissue? Who should be giving the consent to the use of this tissue? And is it the case that actually all reproductive tissue is considered special by those who are producing it? It isn't just the embryo that's special. It is the egg, it is the sperm, it is the cord blood. It's the context that makes it special rather than its biological status. I think we need to think more carefully about the impact of this close interface between IVF clinics and stem cell labs, and have a consideration about what impact that has on the IVF world more generally. And we also have to, I think, be aware of the poignancy of people who are going through this process, wanting to reproduce themselves, wanting to have babies, achieving some sort of immortality in the replication of stem cell lines, even when sometimes they're not actually going to produce a baby. There are issues of governance and commerce, and again, my